Good afternoon, everyone, and welcome to today's webinar, which I think is going to be fascinating at 57 minutes, talking about something revolutionary. It's about how one bit of the public sector can learn from another bit of the public sector. Who thought that would be a good thing? My name's Rich.
I'm Anna Howells. I'm Annette from ADVI.
And delighted to be joined by Amy. Hello, Amy.
Hi.
And Amy's going to be talking with us later on today, all about special educational needs. Amy, you've walked the dog yet already today? That's done? That's
one walk down, only another hour and a half to do.
Hour and a half? What sort of dog do you have?
Huge, a working setter.
Okay. Wow. Can't you just buy a treadmill?
What, and I stand on it and let him go?
Yeah, that sounds fine. Amy, thank you so much for joining. Thank you all for dialing in. We are talking largely about long-term conditions today, but if anyone does want to share any dog-related walking tips, then you're welcome to do that as well. So today we're going to be hearing from Amy. We'll be talking a bit here as well, but we'd love for you to join in. There's 3 ways you can do that. Anna, how can people get involved?
Yep, so the first way you can ask a question or post a comment is to use the Ask Question feature that should be on your screens. You can also tweet using #SusHealthUK, or if both of those options fail, you can email us hello@kaleidoscope.healthcare.
Lovely, thank you very much, Anna. And just to say, we are recording today, so if your IT equipment decides to have a meltdown in the middle, do not fear. You will be able to catch up later on, and you may be watching later on. If so, using the Ask Question feature, probably less helpful, but please do still feel free to email us any comments and reflections after the event. So just in terms of who we are, who you're hearing from, so this webinar is coming live from Kaleidoscope HQ. We're a social enterprise which brings people together to improve health and care, and a lot of our focus is about trying to provoke conversations which need to happen, but often don't, such as the sharing of learning between different fields. We're delighted to be working in partnership with ADVI for this event.
Yes.
Annette, your cue.
Thank you, Richard. As it says in the slides, ADVI is a highly focused, research-driven biopharmaceutical company, and we're really proud of the medicines that we produce to address today's health issues, from life-threatening conditions to chronic illnesses. However, whilst we're really proud of the work that we do, we know it's only a small part of the work that needs to be done to make the NHS sustainable for the future, which is why we've got a long history and will continue to work with organisations and individuals across the NHS to decide and talk about how we can move towards a more sustainable healthcare system. And now, so for us, this series of events is a great opportunity for us to hear from people like yourselves who have joined the webcam, to are working to deliver and improve services in health and care every single day. And as the series says, within this, we're really interested in the practical examples of change, how it starts, how it spreads, and the practical steps that can be taken to get there. Also, particularly whether we can find common grounds across different backgrounds between health, third sector, educational services to really drive that change forward. Because as we know, it's particularly poignant at the moment. The 10-year plan is on its way. We know this is going to be calling for improvements, change across the NHS, and more joined up working across the integrated care system. So we're delighted that Amy is able to join us, and really interested to hear sort of thoughts and insights of everyone who's kindly joined us today. So thank you.
And the Sustainable Healthcare Programme has been going for quite a while.
Yes, since 2013, since ADVI was first initiated, yeah.
Excellent, good. And you're having to shoot off at some point, but thank you so much.
I'm afraid I am, but yes, I'll be watching eagerly at home as well when I get back.
Perfect, lovely. Thank you very much indeed. So just to recap, that your hosts today are myself, Anna, Annette, and Amy. So this series, we've called this series Change in a Cold Climate. There's a whole mix of different events, both webinars, but also face-to-face events, including lunches and learning events. We've called it Change in a Cold Climate, not because we're sort of huge fans of Nancy Mitford references, but because actually I think there's quite a serious point here about how change and improvement can be made in the NHS at a time when it's, to be honest, it is hard. and we shouldn't pretend that it isn't, but we should try and think about how some of those barriers can be overcome. So this whole event series is about this nitty-gritty of how change happens, learning from examples where things have gone well, more than where they've gone disastrously, as we tend to do in health. Do you tend to focus on disasters as well in education, Amy? Is that a common theme?
Yeah, there's a lot of things that don't work and a lot less discussion about things that do work, yeah.
Excellent. Good. Well, a common ground already established.
Yes.
So why are we focusing on change? There's this lovely quote which we use quite a lot from the US economist Paul Krugman. Other economists are available, where he says about sort of thinking about economics that productivity isn't everything, but in the long run it's almost everything. The point he's trying to make there is that within an economy you really need to think about how you are improving as sort of one of the central topics. And indeed, it's the same for healthcare. Healthcare's ability to change and improve is not everything, but in the long run, it is almost everything, because that dictates how we can use the resources available to us. We think there's a particular issue at the moment that if you look at the NHS staff survey, you find that only about 55% of staff feel that they're able to make improvements happen in their area of work. So actually, it's a fairly low, reasonably low level of people who feel actually empowered to make change and improvements within their particular setting. And we're sort of just captivated by this thought, by what if that figure was 90%? What would the NHS look like then? So that's why we're interested in change. We're also particularly focusing on long-term conditions within this series. And here's a set of statistics you've probably heard before, because we do like in long-term conditions to repeat the same statistics over and over again. So you've probably heard at some point that 15 million people in England have at least one long-term condition, and that number is rising and expecting to rise quite dramatically with an ageing population. You might well have heard that about half of all GP appointments are for those with long-term conditions, and about 70% of the primary care budget in England, again, is spent on those with long-term conditions. So it is a big, if not the central issue facing healthcare services about how they can best provide high-quality services for those with long-term conditions. So we sort of, if you could do a virtual hands up on a webinar, we'd probably do that. But probably those statistics are are ones you might have heard before. But here's some which you might not have done. Firstly, that there's no country which appears to have cracked long-term conditions care. Normally at this point in a webinar like this, we'd say, if we only look at what Sweden was doing, then we would be fine. But when you look at international surveys, this one comes from the Commonwealth Fund, which does a international survey of patients every few years around various questions. This one was about asking adults with a chronic condition, did they have a discussion with a health professional in the last year about their treatment options, including side effects. You can see that actually sort of the highest we get is 52% actually having that conversation. So the UK coming at 42%. So no country here, sort of Australia doing a bit less well. No one here is doing sort of stand out. This sort of issue about care coordination, providing high quality care for individuals with long-term conditions is certainly not a UK-centric problem. Next statistic, which is that 10 to 15 years, it's a number of years which multi-morbidity, having more than one long-term condition, appears in people living in the most deprived areas compared to the most affluent. So we often talk about long-term conditions as this big issue affecting the whole country, which of course it is. But in terms of how it cuts on health inequalities, there's a really dramatic differential, which possibly we don't talk nearly enough about. So that's people living in the most deprived areas sort of being affected by some of the issues around multiple mobility 10 to 15 years earlier. That's sort of a really stark illustration of that gap. Richmond Group of Charities doing fantastic work on multiple long-term conditions amongst many others. And then finally, it's the clock which is always ticking, which is that it's now been 46 years and counting since the 1972 white paper. I'm sure everyone's got a copy at home, which said this sort of startling insight. There's a need for far more services that support people outside hospital. Often what there is could achieve more if it were better coordinated with other services in and out of hospital. This is sort of a diagnosis for how do we provide high quality care for people, not just in hospital, but using community settings, particularly those with chronic conditions. This is 1972. You could sort of cut and paste this and put it in any document. There's probably going to be a sentence exactly the same as this in the 10-year plan.
We can imagine, yeah.
No doubt. Why are we still talking about this? A side note that this comes from a day when white papers were a bit more Ronseal, the National Health Service Reorganisation white paper. We don't call them like that any longer. But sort of this insight that there's more to do here, we have been saying for a very long time. So we do need some new insights. If we always do what we always did, we'll always get what we always got, as people often say. And so what we're particularly interested in these event series is hearing a slightly different slant on conversations we might have been having for a long time. So we've been thinking about what learning can we gain for how to meet challenges in improving long-term conditions, so within healthcare, from outside of our field, and particularly, is there learning which we can glean from this sort of specific area of education, special educational needs, which we thought had particular potential for some cross-learning between health and education. I should say I've worked in health for a little bit. I was at the Department of Health for probably far too many years, and I cannot remember once being involved in a learning conversation with any of my counterparts from education about, oh, you're doing something vaguely similar to us. Should we have a chat about that? It might just be me. People might not want to talk to me. But this whole area of how do we greater learning skills we're particularly interested in. And Amy, delighted that you are able to join us today. I'll allow Amy to introduce yourself and to talk about your work. Amy.
Thanks, Rich. Thanks for inviting me along today. As you said, I don't often get invited to speak about what I can share with health colleagues either, which is quite interesting. And I think it's maybe this is the start of a conversation we can continue to have over the 46 years to come, Rich. So I'm Amy Skip, and I'm the director of a research company called Ask Research. And we specialise in looking at factors that affect outcomes for children and young people. So that covers a wide array. It's basically everything to do with child development. So family characteristics, what's the impact of having a single parent family versus a two-parent family, poverty, what factors about poverty affect your long-term outcomes later on in life, education and training, all aspects. Does the curriculum help all sorts of children? What does the curriculum lead to in terms of children and young people's outcomes? But also my particular background means that I've got a specialist interest in special educational needs and disability. So in previous roles, I was the head of research for the National Deaf Children's Society, and I was also a research director in the National Centre for Social Research Children and Families team, which is one hell of a mouthful. So my background really is about a lot of joint working, but also how we can improve ways of working to benefit the outcomes for children and young people. So hopefully I've got some things that I can share with you today that maybe might just spark a bit of interest and make you think about your own practice. I think that's probably the best us as researchers can hope to do. Okay, so if we start with the first slide, what I'm going to talk about today is special educational needs and disability. And before we start, I think it's really important to describe who we're talking about, because actually the fact that this series is focusing on long-term conditions is quite interesting, because I would have imagined that we were covering a lot of the same issues, but it might not necessarily be that case. So a child is defined as having special educational needs and or disability if they have a learning difficulty or disability which calls for special educational provision to be made for them, which is slightly tautological. But what that's then described as is children have a learning difficulty if they have a significantly greater difficulty in learning than the majority of children of the same age, or they have a disability which prevents or hinders them from making use of educational facilities in the same way as other children of the same age. So what are we talking about? We're talking about lots of different conditions. Some of those will be disabilities. So we might be talking about children with hearing impairment, visual impairment, but also, and increasingly, we're talking about autistic spectrum disorder, ADHD, dyslexia might be in there, reading difficulties, processing difficulties, any sort of learning difficulty or brain injury that might be leading to children not being able to access mainstream education in the same way or at the same rate as their peers. And just to give you an idea of the numbers, because Rich had some stats and I love a good stat, we're talking about 15% of the entire school population having a special educational need or disability. And this rises to around 19% when we're talking about post-16. So that's 1 in 5 in every college group has got some sort of special educational need or disability. So in a class of 30, which I imagine is what most of you think of a class size as being, then we're looking at 2-3 children that have very complex and specific needs. But I'll get more onto the detail of how we've differentiated those children as we go along. So if we can move on to the next slide. I think the key area that I want to talk about today is based on the SEND reforms. So a lot of you might think that when a child has special educational needs, they get a statement, and that's what commonly people refer to. So a child had a statement of needs. And what you might not know is that those no longer exist. So a statement of need basically was come up with by the fact that a child wasn't felt to be making the same sort of development or was having some sort of struggles at school, and so the parent or the teacher went to a GP referral. After the GP, anything could go really. So then we know that children could have been seeing a paediatrician, a speech and language therapist, physiotherapist, OT, CAMS, specialist teams such as autism, eating disorder, ENT, neurology. Health visitors might have been involved, the school nurse might be involved, educational psychologists might have been involved, and for some families they actually had to go for individual meetings with all of that array of health professionals, get a different report from all of those individuals, and then maybe or maybe not share that with the school. Now the school is obviously where the child is spending the majority of their time, so there wasn't really a very effective way of sharing that information. From the school side, they would then say, this child has additional needs and so therefore we'll give them 5 extra hours of one-to-one reading support or something like that. It was quite generic. So there were multiple contact points. There could have been conflicting advice. So it could be that the paediatrician said they thought that it was this and therefore at school it would mean this for them. And then the CAMS team might be saying, well, no, actually what they really need at school is this. So it was difficult to decide what the school should actually be doing. And there really wasn't many thoughts about what this means for day-to-day in school. So the SEND reforms were brought about in 2014. That's probably a date I should know off the top of my head, but I think it was 2014. And I think Anna's got the link that she'll be able to share with you all. And they said, OK, let's turn this around rather than making this quite a complex process with lots of different people feeding in very bitty ways and the families feeling a bit lost. Let's switch it round to a more person-centred, holistic care approach. And so what this said was, the child and family should be at the heart of the support. All of the support should be around that family and then feed in, but also they should talk to each other so that they can share information, build up a picture of what the child's needs are, what the child's likely future outcomes are likely to be, and what type of support that might mean for their day-to-day existence and their time in school. And also, rather than giving the child a label, which was quite a deficit model and left some parents really quite uncomfortable, we're now looking at what outcomes do we want for this child. So rather than saying this child has got autistic spectrum disorder, and I know that back in the past some people say, so therefore they're never going to live independently, they're never going to be able to drive and they're unlikely to get a job. What we now do is say this child has this range of specific needs, this range of specific strengths, these ways in which they like to be supported and that help them to achieve. And what this little Johnny really wants to do is to become an astronaut. So what we need to think of is what steps can we take to support him on his journey to maybe one day becoming an astronaut, because that's his aspiration. So it really has led to a change in approach. Also, statements were got rid of. And so now all children who've got special educational needs that are at the most severe and complex end will actually get an education, health and care plan. And so that's about looking holistically, not just at their needs in school, but their social needs, their support needs, the family's needs. And so this has led to quite a big change in the way that everyone's working. And some of you who work in health, this may or may not be part of your daily business. And if it is, I'm sure I'm going to hear from you as soon as I stop speaking, which might be a reason to just carry on. So if we go to the next slide, Rich, the key lessons that I think we've sort of learned from this. So we're 4 years in now. We actually did an evaluation of it a couple of years in, and our advice to government was, it's a really nice idea. It's just taking a little while to bed in. And I think if it was to be evaluated again 2 years on, it would probably still find the same. And those of you who watched the news last night will see that one of the main headlines was, lo and behold, a very big story on the issue around special educational needs. So I'm certainly not putting this out there as a model that everyone should adopt because it's been absolutely seamless. What I'm saying is there's probably some key things about it that are potentially transferable to health, and also a lot of them that affect health. So the key lessons I think we've learned is about joint up working, and I'm sure you've all heard these many times before. But how do we do that? And some of the examples we've found of how that's done effectively are so simple, and yet without having a conversation about them are never going to come about by themselves. So for example, if health and education and social care practitioners need to share information all of the time, what about putting them in the same building? I know it's also, if an education area covers this area and a health area covers this area, then is there a way of making the areas they cover actually coterminous, so that health and education are talking about the same areas and they're dealing with the same children and the same issues? Joint training, it sounds so straightforward, but physically getting the people who are all involved into one room together, listening to the same ideas, principles, and having the same agreed way of working together, the same aspirations for how they want to deliver services, has actually been revolutionary. And as Rich said, for some of them, it's the first time that you've had education and health professionals who all work with exactly the same children and families sat in a room together. And actually for them to talk about the way they want to work and talk about some of the ways that can happen just overcomes a multitude of barriers. Joint commissioning is exactly the same. And that's about whether there are better ways of commissioning services so that there aren't individual bits and pieces all spending their money, and actually it makes it more effective in the use of money as well. Information sharing processes, so as part of the EHCP process, all of those multi-agency professionals around the child need to feed into a report. One of the first things we found, and I hate to say this to people watching today, was that some of the advice that health practitioners submitted couldn't actually be understood by people who weren't health practitioners. And also some of it was quite long, and actually they only have quite a small box to feed into. So what in some areas they've done is produce templates and say, right, these are the things we need to know from you, just fill in this box, don't go outside of it, and maybe write in capitals as well so that we can read your writing. So it's really boiled it down to the basics. We need this from you, we need to know what their condition is, we need to know what that means in terms of what they're likely to be able to do and not do, and what types of things might help them. And then having this whole agreement process, so it's not individuals feeding into the family different things. They all get together in a multi-agency assessment meeting and they agree together, this is the best way forward for this child and family. The thing that's been quite difficult for people to get a grip of, but has really led to a revolution in the way that we see services, is having the patient at the heart. Now, I follow lots of health practitioners on Twitter, so I know that person-centred care is a phrase you're all very familiar with, but it's quite difficult to do. It means not me being the expert telling you stuff, it means me listening to you. It requires time, it requires a proper understanding, and it requires thinking about how you actively involve that patient in their care and support. We also have, we're meant to have, a say it once approach, which is that the family doesn't have to keep telling their story about the traumatic birth, how tricky it's been since then, to all the different professionals they meet. They're meant to say it once in an about me form, and then it doesn't have to be discussed every time they meet someone. And like I was saying, this outcome focus, that's based on the individual. What do you like doing? What do you want to do in the future? What are you good at? Let's build a plan around that. The other thing, and this is quite interesting because this came from a healthcare perspective that we learned this, is about being evidence-based. So Ben Goldacre had done lots of work about evidence-based. Education is now starting to build up its evidence-based. That means that we can track and monitor children's progress and see whether something's working. There's no point continuing to spend money on something if we don't know what it's doing. So mainly in schools, you will start an intervention, you'll give it 6 weeks, then you look at the data again. Has this made a difference? Is it something we want to carry on doing? Do we need to tweak it? And sharing information and knowledge. I think that's all about being evidence-based as well. Next slide, please, Rich, thanks. So when we look at this from a school point of view, because schools are a little bit ahead in terms of how they support children with special educational needs, I think these are the key things that we've learned are leading to success. And there are lessons here for how health could implement their side of the SEND reforms as well. You need a shared culture. You need to all be working in the same direction. You need to have the same belief system, and you need to know that that's where you're going. You need senior buy-in. A lot of the good practice we see is on the ground, and it's individuals doing the best they can, or as parents often describe it, going the extra mile. Actually, you need senior level to understand that as well, because they're holding the purse strings, they're setting the policies, and they're governing how and why most people are doing their jobs. Use of experts is about understanding roles and responsibilities. So I, as an education professional, do not want to be making decisions based on what I think the outcomes are likely to be on a child with a specific neurological condition. I need to know that there's an expert I can go to who can give me advice on that. Flexible approach is based on evidence. So this is like I was saying about tracking. If something's not working, we need to switch to something else. But we're now starting to build up a database of the types of things that might actually have an effect. I'll come on to some of the challenges because they're linked to that in a minute. Effective tracking I've talked about. Personalisation is about person-centred approach, and that requires getting to know the actual person that you're dealing with, not just seeing them as a name or a label. And then most importantly is communication and collaboration. And that's really easily said. It sounds like it's really simple to do, but the reality is in most people's daily lives, we don't get enough time to share chats, to share discussions, to share thoughts, to think about things. And some ways in which public sector is set up actively disincentivises us from sharing information. So we often hear, oh, we're not allowed to share that. Goodness only knows what it's like now GDPR's come in, but it's always been a problem. Can you share information with this? Oh no, I can't, it's confidential. So there's about ways of getting over and genuinely communicating together and collaborating together. If I just go on to the final slide, that's just to flag up some of the challenges, and I won't linger on these, but I will just mention them. So the last slide, please, Rich, is about some of the challenges we've got. Capacity. All of this takes more time. You can't do it in a 5-minute appointment. If you need to communicate and collaborate with someone, you need to actually have time to be able to do that. Also, since the approach has changed, and it's not just about a child not doing very well at school and having something wrong with them, it can now also mean that there's something socially going on, there's something that's not sort of understood going on. The number of children coming forward where parents or professionals think they need extra support has absolutely gone through the roof. And this is causing a real issue for education professionals at the minute, but also I know health professionals. There's a real problem with professional roles and boundaries. We silo work. I wish that we didn't, but most of us do. And so there's real issues with how we work across that. And also competing priorities. The Department of Health is telling you to do one thing, the Department of Education is telling you to do something else. How do you make those two meet up? Same with budgets. This budget's for this budget's for this. So how do we pay for something that sort of sits in between that? The old ways of doing it are really difficult to overcome. If you've been doing something and no one's complained about it in the past, why would you start doing something different now? And we found that quite strongly with a number of the staff that we're working with at various levels in various organisations. And then there's the evidence base. Special educational needs are enormous. They cover loads of things. What we can do with evidence is quite limited because it's about the individual. So, for example, in a recent survey we did a lit review. We found that what are the best ways to support children with dyslexia? All of the evidence shows that using a coloured overlay, which I'm sure many of you will have seen or heard about in the past, has absolutely no benefit whatsoever. It cannot be in any way proven that putting a colour overlay over something helps a child with dyslexia to read it better. So then we survey all schools. How are you supporting children with dyslexia? And guess what they're all doing? They're all using colour overlays, and they all swear absolute blind that that is having a massive impact on those children. So how do we weigh up what the evidence base, testably, peer-reviewed evidence can show and what people are actually telling us from their day-to-day practice. It's very difficult to balance evidence-based and personalisation. Just one of the things that I think I'll mention as I finish is some of the drivers for this. And unfortunately, when we're talking about carrot and stick, we have to mention the stick as one of the drivers. So all local areas now come under a joint area inspection, and that's CQC and Ofsted together, and they come in and they look at the joined up services for children with special educational needs, and they're graded on that. Unfortunately, we found that's quite persuasive for some senior managers to suddenly develop an area of buy-in that they didn't have before. So that has been quite a good stick, I think, to encourage some people to do it. And then there's examples from other sectors. So actually we do learn a little bit from what we know from healthcare. We do learn a lot from what we know about social care, certainly in terms of older children, how we work collaboratively with them. So I think there's lots of things we can share and learn from each other, but I'm very interested to hear some of your thoughts on that. Sorry, that was a whistle-stop tour of special educational needs.
Amy, thank you very much indeed. That was a fantastic overview. And we'll come on to questions in just a second, but I'm sure there are people who have been listening in from health where you can almost play sort of long-term conditions bingo. We need a person-centered, holistic approach with individual planning. And people might be waking up going, hang on, what are we talking about? This is health, isn't it? But some really interesting, I think, differences and similarities, which I'm sure we will go through. Anna, how can people get involved?
Yep, so 3 ways to join the conversation. If you'd like to comment or ask a question, you can use the Ask Question feature that should be on your screens. You can use the hashtag #SusHealthUK, so you can join the conversation on Twitter, or you can email us hello@kaleidoscope.healthcare.
Lovely, thank you very much. And so please do send through comments, questions, reflections. But just whilst you're doing that, if I can take chair prerogative for a moment, thank you very much. Which is, so Amy, I found it really interesting, both what you were saying, which sort of it sounds exactly like the sort of conversation we would have, but actually some areas which you didn't particularly talk about, which we almost would do. And top of that list is money. I don't think you mentioned money once in what was it, 15, 16 minutes. Whereas I think pretty much any new initiative, new drive in health is normally about, well, you know, where's the extra money going to come from, or this pilot's going to have £10 million or whatever. Amy, should we read anything into that? Is it just because you missed it out, or was money actually not particularly a big part of these reforms?
So I guess the reason it wasn't covered in the presentation is that I thought I'd allow myself 20 minutes where I wasn't moaning about the problems we have with funding. Anyone who's watched anything on the news over the last couple of months in particular will know that funding is a real issue for education, and it's not getting any better anytime soon. So there was a massive march in Whitehall last weekend of all head teachers complaining about school budgets being cut. And money is a problem. However, just because we're doing a different way of working doesn't mean necessarily it's going to be more expensive. And actually, if you think about the model that's sort of like the team around the child, I think we'd call it in other areas, there could be ways in which I hate to say it, but it could be more financially effective. So rather than all of these individuals assessing this child over several months, what about if they're all in the room at the same time, having the discussions together? Actually, maybe that's more effective way of carrying out an assessment and agreeing a plan to go forwards. Undoubtedly, there have been real issues in terms of funding this from a health point of view, I'm afraid to say, because people are saying we're suddenly getting children coming to us that we would never have seen before. Just because a child's behind at school doesn't mean to say there's actually anything medically wrong with them, and yet here they are at the GP surgery asking us to find out what's going wrong. So we know that capacity and the linked resources and funding are an issue across this. I just thought maybe we could have 20 minutes where we just pretended that it wasn't the be all and end all. But also it's not, I mean, I might be wrong, but I don't foresee a time when suddenly there's going to be loads of money swishing into either of these sectors. So what are we going to do about it? We can carry on moaning, or we can just think, what are ways around this? Joint commissioning might be one of the ways around that.
Amy, lovely, and it's good to see complaining about funding is a universal trait across any public service. But I think your point there about just because you've got a different way of working, it doesn't have to mean that it is more expensive. I completely agree, and it'd be really interesting to get people's reactions from health on the call in response to that. Can I throw in one more?
Sure.
Is that okay? Sure. Please do send through questions. One more for me, which is the other point, Amy, I think we would normally talk about quite a lot, is data. And so we talk quite a lot. We we always want more, but health is sort of awash with data where you can compare sort of between providers or between areas, between GP practices and hospitals. We've got the staff survey, but sort of huge number of measures and audits and such like. Whereas you didn't particularly talk about data as a particularly key part of the reforms or practice. Is how much data is there available for schools and others to use to improve what they're doing with regards to special educational needs?
So we are also swimming in data. I think the major difference might be about the quality of our data. So parents will think nothing about comparing schools based on their Ofsted rating, and their Ofsted rating is very predominantly data driven. We've got some issues with data. So some of you might know, if you've been comparing secondary schools for your children at the moment, which I know a lot of us have, that you might be considering which data measure to look at for a school. So for example, we've now got Progress 8, which doesn't just talk about how many children get A to C GCSEs, but shows how much children were moved from their starting point to their finishing point, because that's about value added rather than just creaming off the better children. So we've got lots of measures like that. Individual children's progress is monitored really closely. And so the main reason why you would identify a child in the first place is because their progress, their data just isn't tracking in the way that you would be expecting it to, and it's certainly not following the same trajectory as their peers. What we're less good at, I think, is being able to say, so we've got a child who's not making progress in reading, we're going to do a 6-week reading intervention, and then we're going to assess them again. And then we're going to say, how much difference did that reading intervention make? And I think education are just a little bit concerned about how they can say what difference just that intervention by itself made. I don't think we've quite got to that point yet where we feel confident about it. But in terms of our evidence base, the work of Ben Goldacre fed into the education sphere and has led to the setup of a group called the Education Endowment Foundation, which has got a toolkit for schools. And it's meant to take no time whatsoever. And so you look at it and you say, I've got a child who's got issues with their reading. I look along, here's a reading intervention. It costs this much. And on average, it leads to this many months progress. Right, I'll use that. So I think we're getting better at using data. I think for a lot of schools, the main problem is they've got so much data. It's about how you use it, not having it.
Okay, great. It's good to hear yet another common theme. Anna.
Yes, and thank you all who've asked a question already, and please do keep sending them through. The first question is from Rose. Thank you, Rose, for this one. So Rose's question focuses on the need for health and education to work more closely together, and she gives the example of struggling to get children into child and adolescent mental health services, and then practitioners not being able to go into schools, and kind of the disconnect between those two, and just ask your views on kind of how to make that happen, or what approaches you've taken. Nice, easy one.
Yeah, if I knew the answer to that, I would be a very rich woman. CAMHS is our biggest area of concern, I've got to be quite honest. And as soon as we start talking to educationalists about special educational needs, CAMHS will come up in conversation. So that is down to money and capacity. There are so many children and young people with social, emotional, mental health, well-being needs. That is the greatest group that we're seeing an increase in. So when I speak to colleges, they say, oh, we're not worried about the kids with autistic spectrum disorder because we know what to do with them. You know, we've got strategies in place. We're not worried about the kids who've got dyslexia. The ones we're really worried about are this biggest group and the quickest growing group, which are social, emotional and mental health needs. CAMHS thresholds, because they can only take so many children and young people into their service, has to mean you have to be very, very, very severe before you can even be considered by CAMHS. That is a real concern for schools, because it means that schools are having to pick up that area, and I think they are very, very uncomfortable about doing so. There are lots of initiatives. So, for example, an organisation called The Place to Be puts counsellors into schools, and that's actually supported by, oh crikey, what is she? She's married to William and she's called Catherine. I think she might be the Duchess of something, Princess of something. So she's a backer of that. So it's got quite a high profile. Schools really love it. But again, it's about what's appropriate. If a child needs CAMHS, my feeling is they should be seeing CAMHS. But if we can't get them in, what do we do in the meantime? And I think a lot of schools are very nervous that they're holding some children and don't know what to do for the best. And then it becomes a safeguarding issue. So sorry, no answers.
No, but if you find them, then we look forward to your wealth, and hopefully one day you'll be on a stage, I mean, where there'll be a royal come up, so you can say, this is the princess of somebody or other. So that's great. More questions?
Yeah, indeed. Heather, thank you for this question. So Heather mentions that she heard a lot of similarities between your talk and multidisciplinary teams that we have in health and care, and that you mentioned the use of experts. So what space is there for experts by experience, the children and their families, and how have they been involved in the process?
So I think the CAMHS actually would be a good example of that. At what point is it appropriate for a teacher, a teaching assistant, even a pastoral head of year or head of inclusion to be dealing with a child's social, emotional and mental health needs? And at what point do they say, do you know what, I'm out of my comfort zone here, this is not appropriate, this is not suitable, we need to bring in an expert? And I think the problem at the moment is that we can't always access the experts that we want to. But also about autism, children with autistic spectrum disorder. Just because you've worked with some children with that condition before doesn't mean to say you necessarily know the right way of dealing with them all the time. And so I think it's about realising there is still a place for expertise. Multi-agency working shouldn't mean that we all go back to the lowest common denominator. It means respecting individual members of that multi-agency team's expertise. And so at what point is it appropriate to get someone to actually give us a neurological assessment on this child? At what point is it appropriate to say, we think this family needs support, so we need to signpost them on to early help or something like that? I think it's about people not feeling they can do everything and sort of ending up muddling through. It's about respecting what individuals around that multi-agency meeting table bring to the table and making sure that we can refer it on appropriately when we need to.
Right.
Thank you. We have a reflection from Laura. Laura, thank you very much. So Laura's a chair of governors and has also worked in health policy for many years, so straddling both sides. On the individual level, data is much better for children than for people with long-term conditions. And as Amy has said, there's attainment and progress data at the individual child level, which is reviewed regularly by teachers and governors. But she can't think of a single long-term condition where the data is looked at from an individual level and intervention supplied if required. So not everyone even has a care plan.
Well, thank you very much indeed. So that, I think that's a really fantastic point, in terms of, I mean, it sounds like your data starts with the child in front of you, whereas our data often starts with the provider, which is overseeing services. Is that a fair characterisation of the data in education?
Absolutely. So every school would be expected to be able to show the data on an individual child. I suppose the point I was raising is how good quality that data is. But if healthcare don't have that data at all, then maybe we don't need to worry about the quality. We've got some and we should be glad for it. But it's also, I hear loads and loads of schools who say, oh, we do a mass data collection every half term. The question for me isn't what data are you collecting, it's what are you using that data for. I believe that data should be used to inform decisions you're making about how you deploy staff, how you teach a certain child. So it's about having confidence in it. And also, if schools are judged on some of their data, and I don't know how much you have this in a health arena, can you choose to go to one hospital rather than another, or one GP rather than another, in the same way you can with schools? They're competing for children to come to them. So there is a benefit to me as a school to make my data look really good because I really want parents to come to my school. And so I think there's some questions about that. So there's a really good example where we have entry data and attainment data. So your entry data can be really high. You can sit every kid for every exam that's going. But as a parent, I'd want to be looking at how that weighs up with the attainment data, because if your entry is really high, but your attainment data is really low, that might not be a school I want my child to go to. And yet a lot of parents will just be looking across at entry data.
Amy, thank you very much indeed. I think a really interesting point there. Well, firstly, we could go into a 3-day conference now about whether patient choice exists in the NHS. And let's not do that. But instead, there is. You talk about the competition between schools, and it's obvious that part of the reforms have shown areas which are doing this better than others. Can you just talk about how we talk a lot about spread of best practice in healthcare? How do improvements get shared between schools, both locally and then more widely?
Yeah, it's a really good point, because there's no point Cheshire having fantastic practice, but Manchester having used this practice. What I think everyone's invested in is how we share that out. And actually, it probably happens better at a regional level because they're not in competition with each other than it does at a local level, which is interesting. So we have some examples of like a hub and spoke model, where a school that's especially good at doing some sorts of interventions or supporting some sorts of children and young people will be given extra money to then support others to develop their practice. Educationalists love a bit of Twitter, they love a conference, they love having a day out of the school, but they are quite good actually at sharing practice, and the department is quite good. I do have to actually acknowledge this, that the Department for Education does a lot of research to find out what's going on, what's good practice. I probably get commissioned most frequently to write up case studies of practice that other areas can learn from. Whether we find out whether people are using those case studies to learn from, then I'm not sure. But for example, I've done some research that's shown what schools want to know about a case study in order for it to be useful for them. So if I just write about good practice, for a school to be able to think, could I apply that? They need to know where that good practice came from. So what was their school characteristics? What area were they in? Were they metropolitan, rural? Did they have a lot of children on free school meals, or actually were they in a lovely leafy suburb? Because it's only when you know things about that that you can actually think that makes that applicable to my setting as well. So I think teachers are generally very good at sharing good practice. There are lots of networks. So for example, you would have a network of modern foreign language heads of department, a network of mathematics heads of departments, networks of teachers, head teachers, deputies. So there's quite a bit of that going on, and there are 1,001 blogs about education, practice, mainly opinion, but people seem to quite engage with that, which is interesting when they say they're all very busy teaching.
Excellent, Amy. I'm sure if there are any teachers on the line, they're probably sitting there going, "Oh, look, we're pretty good at this." I think your point about having those case studies which are context specific and that they're aware of how areas are different certainly rings true, and something which we talk about quite a lot. And so I find that fascinating in terms of that hub and spoke money. That model where schools are given a pot of money to deliberately support others in doing something which they do, which I'm whacking my brains about how much we do that in health. That we're a big fan of having big pilot programs where we give providers lots of money to do interesting things themselves. How much that's about supporting others do it. I much had a blank, but I can't really think.
I can't either, but it just kind of sprung a question into my mind, which is how much room for failure is there in that model, Amy? Because I think when we were talking about big pilot projects that we have in health, there's not much room for failure in those, and I just wondered if it's any different in education.
Well, I've evaluated lots of things that show they've had absolutely no benefit whatsoever. So yeah, I would say lessons can be learned. I think education is quite aware about the need to rule things in as much as rule things out. So, you know, there are lots of approaches and interventions and strategies that you can buy as a school. Schools are there's always people trying to sell them stuff. I'd be interested actually to know if this is the same with medicines, because there's reps going around all the time. You've got to have this, it's the latest thing, it'll only cost you £5,500 and, you know, it will transform all of your children. I think there's more of a feeling that people want to say, okay, show me, prove to me that that will affect my children in the way I want it to, and yeah, you can have my money. But I think people are getting sharper on that, and so there is a lot more about prove to me. And I think there's more understanding in early teacher training now about how to understand data. And so they're actually making more informed decisions about what evidence is showing them. So, you know, it's like the shampoo adverts that say 93%, and then in small print at the bottom, of 4 people who are all related to the chief executive of this company. I think people are getting a bit more savvy about how to understand what people are actually showing them, and about understanding what that means for the children in their area, because there is much more of an understanding now about the fact that not all schools are the same, not all children are the same, and so getting more nuanced, I think, in the way, and that's about personalisation, building up individual support plans for individual children. That's probably the current big thing.
Lovely. Amy, thank you very much. Just say we've got 6 minutes left. We're nearing on time. So if you've got any final questions, reflections, please do send those through now. So we'll take final points, and then we'll do some reflection before we close. We will finish at 2. Amy, I was just going to take us back to one of your slides in terms of your key lessons, which I particularly like because actually so much it was familiar to us in health. And I think the message I really took from that was there is no magic bullet which we can look at education and go, they've solved it in a completely new way. But there is something about being committed to a set of things which may even be fairly common sense, but then seeing them through. And I particularly, just in your joined up working point, just the basics of co-locating, of joint training. I think that's something in health which we could do a huge more about not just talking about joint commissioning, but actually doing it. It seems like one of the key points which has come through from your studies, Amy, has just been success has gone with commitment to basics just as much as it's been to something newfangled and whizzy.
Yeah, and I sort of have a little bit of a concern about this as well, because when I find good practice, when we try and boil down what it's coming down to, it tends to be a committed individual. Parents always say someone who's willing to go the extra mile. And it shouldn't be about being willing to go the extra mile. That should be the first mile, if that's the right way to use that metaphor. But yeah, a lot of these sound quite simple, but they're simple to say and not necessarily simple to do. So being outcome focused and patient based, I'll just give you one example. Unfortunately, it doesn't reflect quite so positively on health professionals, but the example I gave about little Johnny wanting to be an astronaut, when we did a joint training about that and said, okay, so we need to think, if that's his aspiration, what do we need to do? We need to see if we can help him to walk. We need to see if we can help him to read and write. But health professionals were quite reticent about signing up to that, because they were saying, but he's not going to be an astronaut. We don't want to be sued. And so it was about having those open discussions and saying, well, no, you won't be. And just because you feel uncomfortable about that doesn't mean to say we need an outcome focused approach. So yeah, it's the basics. It's probably people with a good kind heart, but you can't write policy that's dependent on that, and neither can you write policy that goes down to the minutiae of you should try and be a good person. It sort of comes as part and parcel of the job, but it's the one thing that we can't allow for. There was just one other point, Rich, that I wanted to share that I think's useful, and that was about something that's really been at the heart of these reforms, which is about parent support. And so alongside all of this work that's happening amongst professionals, they also had to set up a local area forum for parents, because we know that parents supporting other parents in similar circumstances, peer support, peer sharing of information, talking to someone who's in the same situation as you or who maybe is a little bit further down the line, there's so much to be gained from that and so much to be learned. And I've just written a paper about peer support, and nearly all of the examples that I found that were positive were from a health context. So when you were saying about stuff not happening outside of the hospital, actually, I've just been reading loads about stuff that's happening outside of a hospital. It probably isn't led by professionals, that's sort of the point of it. But in terms of long-term conditions, parents of children with disabilities, we know the best support they get in a lot of ways is from each other. And so we need to facilitate that meeting up.
Lovely. Amy, thank you very much. We've got 2 minutes to go. So we're just going to move to final reflections. Amy, thank you once again. So we're just going to go round. I'll start by my colleague's time, then Anna, then Amy. Just one particular insight which has struck us over the last hour, and then we will close. So I think the point which really sticks for me is there's some quote which I can't remember at all, which is about when you sort of travel far away from home, you realise more about home than when you were there to begin with. That sort of seeing sort of a changed journey through a different area's eyes does make you realise just how much within health we do know what to do, but we just don't do it. And your point about a lot of these things being simple to say, not so easy to do, Amy, really hits home. Anna.
Okay, thank you. I think definitely what stood out is the kind of some of the similarities of experience between health and education, but in particular, Amy, I was really interested when you were talking about sharing best practice and some of the different models that you use in comparison to health and perhaps what we have overlooked.
Thank you. Amy.
I think for me, it's about the stuff that I think we presume health are doing that potentially they're not doing or not doing quite as well, or maybe we're not quite so bad in education as we thought. So I must have the same webinar for an education audience in future. I presumed you were incredibly evidence-based at the individual level. I presume that's how you make decisions about the type of care that you're giving to an individual, because that's certainly the type of model. It feels a bit medical model that we're using. So I think there's something to look at there about what we can pat ourselves on the back for, but also how we can think about sharing more information and just having a more open conversation more frequently, I think.
Amy, thank you very much. Well, if we've done nothing else, then we've used healthcare to show that people in education aren't as bad as thing. I'm not quite sure where that leaves us. But to say, Amy, thank you once again for joining. Thank you, Annette, who was here earlier. Thank you, Anna. Just to say that this is part of an event series. All of the details about upcoming events are available on the website, kaleidoscope.healthcare/change. We'll send that link around for all of you to see. Please do join us at a future webinar or at a face-to-face event. Thank you once again for joining. And we hope to see you at a future again. Thank you, Amy. Thank you all.
Thanks. Bye-bye.